Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today, July 25th, 2025. This video is on a consensus statement published 23rd July 2025, open access. It's a call to action. The British and Irish Hypertension Society position statement on blood pressure therapy thresholds and targets, published in the Journal of Human Hypertension. What is the new treatment threshold for blood pressure medication in this call of action? Start blood pressure medications at systolic blood pressure greater than 135 and diastolic greater than 85 millimeters of mercury, regardless of cardiovascular disease risk. What is the target blood pressure once therapy has been started? Is less than 130 by 80, or inertia, that is as low as reasonably achievable without side effects within 6 months. Does the target vary by the measurement method? No, it applies to office, ambulatory, and home blood pressure monitoring. What does inertia mean? As low as reasonably achievable without side effects. Are there exceptions? Yes. Frail patients or those with limited life expectancy. I would argue also those with orthostatic hypotension. How does this differ from the NICE guidelines or the NICE guidelines? NICE uses cardiovascular disease risk, but this call of action proposes a uniform approach. Why simplify the approach? To reduce therapeutic inertia and improve outcomes. Are adverse effects a concern? No. Significant increase in serious adverse events. Why remove the cardiovascular disease risk prerequisite? Early prevention with safe, affordable treatment is prioritized. Where can one find the treatment algorithm? It's in the British Irish Hypertension Society 2024 Adult Hypertension Referral Pathway Statement. The rationale for removing this cardiovascular disease risk prerequisite is grounded in both ethical and clinical considerations. The first is preventing delay in therapy. Relying on a 10-year cardiovascular disease risk estimate delays treatment until the patient's short-term absolute risk becomes high, by which time irreversible end-organ damage may have already occurred. So this call of action challenges the ethics of this wait-and-see approach when safe interventions are available earlier. Second, evidence-based justification. Recent large-scale meta-analysis, example the one published in Lancet, shows consistent benefit from blood pressure lowering across all baseline cardiovascular disease risk strata, with proposed major adverse cardiovascular events reduction per 50 millimeter mercury drop in systolic blood pressure, even in those with low to moderate risk. Cost effectiveness and simplicity. Antihypertensives are inexpensive, widely available, and generally well tolerated. A simplified two-step approach treat all confirmed hypertension with a target less than 130 by 80 millimeters of mercury. This reduces therapeutic inertia and eases clinical decision making. Global alignment. The British Irish Hypertension Society proposal aligns with international guidelines, ACC/AHA, ESC, that favor threshold-based initiation over risk-based models in most patients. In summary, eliminating the cardiovascular disease risk prerequisite is a strategic move towards universal, early, and equitable hypertension treatment, minimizing preventable morbidity and mortality. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.